Good afternoon. My name is Adrian Dix. I'm BC's Minister of Health. To my right is Dr. Bonnie Henry, BC's Provincial Health Officer. This is our COVID-19 briefing for Tuesday, February the 1st. We're honored to be here on the territory of the Musqueam, of the Squamish, of the Tsleil-Waututh First Nations, and we're honored to be here today on their lands. And as you'll be aware, Dr. Henry will be giving a presentation today, and so the slides will be available through the BC CDC's website and through government websites after the presentation. And with that, it's my honor to introduce Dr. Bonnie Henry.
Thank you very much, and good afternoon. Thank you for joining us today on the first day of the Lunar New Year. And hopefully that gives us some optimism for our future as well. I want to start off today by talking a little bit about our treatment update. So as you know, 2 weeks ago, Health Canada approved another tool that we have in our toolbox to help us manage this pandemic, and that is a medication called Paxlovid, which is a combination of two drugs, nirmatrelvir and ritonavir. And it was given, one of the things that we needed to do was get a better understanding of who would best be suited for this drug here in British Columbia and how we could use it with the limited amounts that we received to begin with. So our BC COVID-19 Therapeutics Committee, I'm very grateful for all the work they've been doing over this past 2 years. They set about trying to come up with our rational approach to how we're going to use this. This is another positive step forward in our COVID-19 journey, and the treatment is specifically for people who are at highest risk of having more severe illness and hospitalization, and it needs to be started within 5 days of symptom onset. So for that, of course, we need to make sure that we have testing available for people. So we've been aligning both the limited supply we have, about 4,000 treatment courses of these medications, with our testing strategy as well. And I'm very grateful for the infectious disease teams in each of our health authorities. We have developed a hub and spoke model so that this medication can be available through our infectious disease teams, and they are able to identify people who are, for this very initial supply of medication, who are most at risk and who we can get it to in that critical period of time. And you will recall 2 Fridays ago we presented a heat map, and we use that information to identify those people in British Columbia who are more at risk of requiring hospital care. And we've identified that it is essentially the people who are in our critically extremely vulnerable groups 1 and 2. So those are those people who have immune compromising conditions because of medications that they're on, because of having had a transplant or undergoing certain cancer therapies. So those are the people who will now have access to this drug. The things that we are learning, though, from this medication is that these are conditional recommendations, and this is a very challenging medication combination. Every medication comes with risks and benefits, but this new antiviral combination has some very important what we call contraindications, so it can't be used in some cases, and it also has some very important drug-drug interactions. So unfortunately, many of the people who would potentially benefit from this medication take some of those medications that interact with it. And it makes it very different from some of the other antivirals we have, like Tamiflu, for example. So people with we have to be mindful of people's kidney function, the immune suppressant medications they're on, anticoagulants. These are some of the very serious interactions. So our teams who are most familiar with using these antiviral drugs, particularly ritonavir, which is a protease inhibitor, it's part of a combination of drugs that we also use for treating people with HIV, they will be starting to offer Paxlovid and to people in the highest risk groups, and we'll be reaching out to them through a proactive process of monitoring our lab data. So it is important, if you are one of those high-risk people, to continue to access lab testing, as you are part of the testing guidelines. And along with this, we will be posting later today some of the detailed information for people so they can look at whether they qualify for this medication, but also the updated testing guidelines to make sure that people who do qualify for it are able to get a test quickly and rapidly. And I just want to say my thanks again to our infectious disease teams and the health authorities, but also to the teams at the BC Renal, BC Cancer, and BC Transplant, because we know that you'll be reaching out and having these discussions with your high-risk patients. This, of course, is another tool, but as I said, there's still much that we need to learn about how to use it and who it can be used in and what the side effects and the risks and benefits are. And most importantly, it is used once somebody has been infected and is at risk of having severe enough illness to need hospitalization. And we know that the most important thing we can do is prevent infection in the first place, and particularly in people who are at high risk, the importance of vaccination. And that is one of the things that reminds us that we need to pay attention to increasing immunity, particularly if you are somebody vulnerable. And so in that light, in mid-January, we shared that we were updating how we'll report on hospitalizations to provide a more fulsome account of everybody who is in hospital with COVID-19 positive test on any given day. And we are at the highest levels of people that we've had in hospital in this whole pandemic. Hospitalizations are what we call a lagging indicator. It takes time, and we have had very high levels of transmission in the community for some time now, and we have seen this translate into hospitalizations most recently. And this is where we are experiencing at the moment. So I'm going to walk us through the information that we've done to look at who is in hospital right now. When we presented the updating reporting, we talked about the census data. So it includes everybody who's in hospital because of COVID-19, whether the COVID-19 is causing respiratory illness or exacerbation of other underlying conditions like heart disease or lung disease. So people who are admitted because of COVID-19. And we're also looking at people who are admitted to hospital with COVID-19. So they're admitted for another reason, and they either acquire it in hospital or somebody is screened or tested with either very mild illness or because they've been screened on admission. And those are the people who are admitted not because of COVID-19, but with a positive lab test. And we need to understand those two populations to help us understand how we're going to get through this phase. So what we have here is a familiar slide of the pandemic to date. What we've seen in terms of hospitalizations, and particularly what we're looking at in the last month. So we've had 63 new people. We've had 706 new people admitted to hospital this week as of the 30th of January, the week ending the 30th of January, out of 11,539 new cases. As we can see from the blue line, it does look like we are at our peak of hospitalizations, and this is where we would expect to be, given the modeling that we've been using to help us understand the trajectory. The other thing that we look at, of course, is by age. Who is getting admitted in higher rates than others? And what we are seeing that it's coming down along all age groups. That bump up that we saw in the younger 0 to 19-year age group has leveled off and is also starting to come down. So when we look at who is in hospital, there's a number of important things to look at. One of them is what is the variant of concern that's causing hospitalization right now. So as we can see, it takes a bit of time for us to do the whole genome sequencing once somebody's been admitted to hospital to understand exactly what strain they have. But it's very clear that as we've progressed into January, Omicron has been more and more of the cause related to hospitalization, the strain related to hospitalization overtaking Delta. Although we still have people in hospital with Delta, people being admitted because of infections with Delta as well. If we look at the characterizations of people who are hospitalized, using this breakdown between Delta and Omicron, we can compare and see what the differences are in what we're seeing. And one of the important things we're seeing is that Delta, for the most part, was very strongly, hospitalization from Delta was much more common in people who were not vaccinated. Now with Omicron, the unvaccinated are a smaller proportion. And partly that's because some of the people, a good proportion of people in hospital, and I'll have that data to show you, are people who are admitted for other reasons and have a positive COVID test. So it's not COVID that's driving them into hospital. The median age is about the same, and I think this is something important. Early on, when we were trying to understand if Omicron causes more severe illness than Delta or not, we were seeing it more in younger people. So it was hard to tell if it was because people were younger and vaccinated or because it was milder in and of itself. We are now seeing that we're in that older age group that is requiring hospitalization. So that gives us some hint. We're also seeing that the proportion of people over age 80 is now higher, which gives us a sense as well about two things. One is people over age 80 are still at highest risk of having severe illness. This is something we've seen all along, whether they're vaccinated or not. We also know that people over age 80 are much more likely to have other underlying illnesses, which may be a reason why they are admitted to hospital and could be screened for COVID. The length of stay that we're seeing, which is really important in how we manage our hospital care right now, and the burden of people who are in hospital right now, particularly when we know that healthcare workers are off with illness themselves. So what we are seeing, thankfully, is that we continue to see a shorter length of stay, approximately half the time that people are in hospital with the Omicron compared to Delta. And so that does mean that people who have been admitted in December and January are still in hospital, and many more of those people would be from Delta that are in for a longer period of time. We also thankfully see a much smaller proportion of people requiring critical care. So that is either supplemental oxygen in the ICU or ventilation and other important interventions to keep the circulation and blood system going. And we are also thankfully seeing a much lower rate of death in people who are hospitalized, about half the rate now. So what does this mean overall? So if we look at our hospital admissions, and this is done from detailed chart reviews of 550 people across the province. So I had presented 2 weeks ago some very similar data that came out of Vancouver Coastal. We've now done the chart review of the 550 people who were admitted to hospital. So they're on admission. Some of those people are still in hospital today. Some of them would have been discharged by now. And this is across the province, and broken it down by people who were admitted to hospital because of COVID-19. So the reason for admission was because they had respiratory symptoms and or exacerbation of their underlying conditions because of COVID. And we see there's 218, about 40% of this chart review were people who were admitted because of COVID. And about 16% additionally required critical care. And over the period of time that we looked at in December and January, there were non-COVID-19 related admissions where the reason for admission was not related to COVID-19, but they had a positive COVID test, and that was about 244 or 44% of the cases. But when we look at this by breaking it down by the variant of concerns that we know are causing infections in hospital, we can see that for people with Delta, it is primarily people being admitted because of COVID-19, and a much higher proportion of those people are requiring critical care. And so that's important for us to know. This issue of people who are admitted to hospital with other diagnoses and test positive really is related to what we are seeing in the last few weeks as Omicron has spread so much in the community. And we can see that about 60% of admissions that were related to Omicron were not because of the infection, but people who were admitted and tested and found to have a positive test. So this is important. And for those that we don't yet have the whole genome sequencing, we see that the pattern, though those are more recent cases for the most part, the pattern is very similar to what we're seeing with Omicron. So that's telling us as Omicron has spread in the communities, we are more likely to pick it up when people are admitted to hospital for other reasons. And those other reasons are what keep them in hospital or require are reasons why they're in for a period of time. There is, of course, still unimportant, about 40% of people who are admissions because of COVID, because of their underlying illness, and a much smaller proportion compared to people who are admitted with Delta infection are people who require critical care. So obviously we want to see how that breaks down by vaccination status as well. And we can see, again, a different pattern for Delta than for what we see with Omicron. So particularly, as we were calling it, and is so apparent when you look at this, that having at least one dose of vaccine, so this includes people who have 1 dose, 2 doses, or 3 doses. So any vaccine is very highly protective when you had Delta circulating in the community. And for people who are unvaccinated, you were much more likely to end up with needing hospital care, and we'll look at age in a minute, and a much higher proportion required critical care. So this is important. As we've moved to Omicron, we see that the incidental cases are much more common in people who are not vaccinated, people who have at least 1 dose of vaccine, and you're much less likely to be admitted because of COVID-related illness or to require critical care. And the pattern that we're seeing in those who we don't yet have the variant of concern is much more similar to Omicron. Again, it just shows us the importance and how we're getting through this phase of this pandemic with so much transmission of Omicron, how important it is that vaccination is preventing people from needing hospital care because of their COVID infection. The other part that we want to look at is this different by age? And the answer for that is, again, yes. So if you are admitted for COVID, you are much likely to be younger in Delta. So Delta is causing more severe infections in younger people, and as we've just seen, in younger people who are more likely to be unvaccinated. Whereas with Omicron, in younger people, it's much more likely to be an admission for something else where you had a positive screening test for COVID-19. And finally, just trying to put this all together and determine if Omicron itself is less virulent than Delta. We do see that seems to be the case with the data that we have that shows that if we match everybody and regardless of age, of vaccination status, of the other comorbidities you may have or other illnesses and sex and health authority, that there's about half as much chance of being hospitalized with Omicron. The odds of being hospitalized with Omicron are much less than with Delta. But importantly, 1.3% risk of hospitalization is still very high when you have thousands of people a day who are being infected. And we see from these data that it's incredibly important that the high levels of vaccination that we have in our communities across the board, across age groups, and across communities has made the difference in ensuring that our hospitals were not overwhelmed in this past few weeks. So what does this tell us? 90% of these new hospital admissions are Omicron, as I mentioned. People with Delta stay in hospital longer, are more likely to have severe illness, and the vast majority of those requiring care in hospital were a result in Delta were a result of actually from COVID. Today we have far more people in hospital than we've ever had. And many of those people, as much as 60 or 70% now, especially younger people, are there for other reasons and they've tested positive. And so what this tells us is this is really important. The level of immunity that we have in our community has protected our healthcare system at this most critical time, even when we've had the numbers of people who needed that hospital care. So while it is under severe strain, it is the credit of so many who have stepped up and got that protection that our hospitals are coping, even though we're stretched. The other measures that have made a difference, and we know that, is intervening early with some of those measures in our community that reduces the risk of transmission, reduces the number of people that we've been in contact with. So that has been an important measure as well, and we're looking forward to when we can start to lift some of those measures. But right now, it still remains important to do those things that work, knowing that 1.3% of 2,000 people a day or 1,500 people a day is still a large number of people who could need hospital care. So with the increase in transmission in our communities, we've also seen an increase in people who have COVID in our long-term care and seniors assisted living facilities, and we've seen that reflected in the numbers of outbreaks that we're seeing. And while there is no question that, again, our seniors and elders in care are being affected, we are seeing a difference very similar to what we saw in hospital, where the severity of illness for most is far less. And this is absolutely because of the very high levels of vaccination and booster doses in residents of long-term care and in staff. In previous surges, we needed to take blanket measures, one size fits all across the province when we had high levels of community transmission to prevent this virus from entering into our long-term care homes. Those protocols had impacts themselves, and we know that. Now, while some measures continue to apply, we are adjusting this outbreak management approach, reflecting very high levels of transmission, but much less severity for most people because of that high level of protection we have through vaccination and through short-term protection through people who've been infected now. So this one-size-fits-all approach is no longer applicable, and we've updated the guidelines around management of long-term care and visitors in long-term care, and those will be posted on the BC CDC website later today. I will remind people we do have some measures in place that were put in place in December as Omicron was starting to increase, and because of all of the transmission that we're seeing in communities. So this includes things like reducing the numbers of visitors. It's important that with the vaccination status of staff and visitors and residents, making sure we got booster doses into everybody, and wearing PPE at all times for healthcare workers, and when visitors are in, making sure that they're wearing PPE, that they only visit the person that they're there to see. But we are also acutely aware of the impact of the extended social isolation that comes with the full closures of long-term care homes. And we've been trying to find that balance of minimizing the risk to residents in long-term care, minimizing the transmission of the virus, as well as finding that balance of having that all-important contact with our loved ones and making sure that we can have those social interactions that are so important. It is important that we continue to have that balance, and doors will be kept open right now. That is the way that we've been trying to manage this, to allow all residents to have up to 2 visitors, one at all times, regardless of whether there's an outbreak, whether there's some COVID in that facility, and the community transmission rates. So this is one essential visitor. About a third of residents of long-term care have an essential designated visitor already. But for every resident of long-term care, they can have a designated visitor. So that can be 2 for some people, but a designated visitor for every resident of their choice. And yes, you can have a backup in case you can't go, but one at a time, making sure that we do have that all-important connection with at least one additional person, and for many people, 2 additional people. even if there are cases of COVID in the facility. What remains unchanged is that these visitors must be fully vaccinated themselves. That's how we manage this risk, and must continue to wear PPE. When it comes to declaring an outbreak, we are using a criteria approach based on judgment and the scope and severity of the outbreak. And there are a number of different factors that medical health officers with our teams of infection control and support for each facility and working with the facility use when an outbreak, when there's transmission within the facility, and whether an outbreak needs to be declared and what measures are in place to try and manage that. We also have updated our guidance around timely communication of outbreaks and cases in long-term care and assisted living homes. So those details will be posted today. Our focus continues to be to protect those who are most vulnerable to severe illness, whether it's in the community, in long-term care, in hospital. And that's why we all need to continue to do the measures that we're doing to protect our healthcare system, to make sure we can get through this wave too, and to keep our communities open and going as much as possible. It's about finding, once again, and keeping our balance. We know that COVID-19, this virus, is going to be with us for some time still. But we are progressing through this surge, which means we can look very soon at starting to gradually ease restrictions in the weeks ahead as we get closer, and we've put limits on some of the restrictions on events and gatherings that will be coming up for review in the middle of February. And we'll look at where we are in our journey through this phase by that time. As we've done previously, it will not be a flick of the switch. It'll be, again, increasing the dimmer switch, a gradual turning of the dial, so that we can do this cautiously and not put people at risk as we're getting closer and closer to the end of this wave. It is a new lunar year, a new month, and a time for cautious optimism. But we still have ways to go on our journey yet. And we all need to continue to do our part as we progress through this pandemic together. Thank you.
Thank you very much, Dr. Henry. And I wanted to start by talking about the continuing and extraordinary efforts of our vaccination campaign across BC. 10,778,839 doses administered as of last night. That's 4,460,130 first doses, 4,166,205 second doses, 2,152,504 third doses, which is, in this recent period, an extraordinary effort. I might add, in addition to that we see a very significant number of young people, now over 50% of children 5 to 11, I should say, who have received their first dose of a COVID-19 vaccine, and that number as of last night is 182,958. And an additional 12,300 with second doses and 28,000 with booked second dose appointments. So that process is going on and moving forward really effectively. I think that there's often a discussion about differences in between vaccinated and unvaccinated. But what that represents is 93.1% of people who have received their first dose immunization of adults who have received their first dose immunization against COVID-19. So when we talk about divisions, it's 16 people vaccinated for every one person unvaccinated. And I think what we see, in fact, and we've seen in our vaccination effort from our teams of medical professionals, of our teams of volunteers, of our teams of communities and municipalities who have supported it, and of the many and of the millions of people, including the more than 4 million people who have and are using their BC vaccine card, extraordinary amount of consensus in our joint effort and our joint commitment to one another to help us get through this. And we see this every day, in every way across the system. We see it with family members finding different ways to support people in long-term care, and the announcements made by Dr. Henry are gratifying for many people in this group. We see it in how we help one another. We see it in people sometimes dropping off meals when people are in isolation to make their lives better. We see it everywhere. And I think, well, there is always going to be discussion of divergence and conflict. The level of consensus and collective effort here in BC is something of which we should all be very proud, and I certainly am in particular. I want to provide an update today on where we are in terms of acute care, just not in terms of people in hospital with a positive test for COVID-19. Dr. Henry has been talking about that, but overall in the system. As you know, there are 9,229 base beds in our system. Today, 8,776 of those are full. We have 2,353 surge beds across the acute care system. Today, 582 of those are full. So that's a total of people in our acute care system that is 9,358. So that is above the base bed level, well below obviously the base and surge bed level. But what it tells you is that our hospitals are very busy providing exceptional care to a lot of people. In terms of critical care, we have 510 base critical care beds and 218 surge beds. Of the 510 beds, 448 of those are full today. Of the 218 surge beds, 30 of those are full today. So that's a total of 478 people in critical care. I want to give a brief update on the impact of sickness on healthcare workers and the healthcare system. Health authorities obviously continue to closely monitor sickness levels across health services, especially in hospitals, long-term care, and home support. I can report from January 24th to 30th, 17,756 healthcare workers called in sick. That includes 4,033 in Fraser Health, 3,456 in Interior Health, 1,656 in Northern Health, 1,773 in the Provincial Health Services Authority, that includes the BC Emergency Health Services, 2,714 in Vancouver Coastal Health, 3,406 in Island Health, and 718 in Providence Healthcare. This is the number of healthcare workers affected and does not reflect the number of days or shifts they may have called in sick. The illness could be due to COVID-19 or something else. The number of healthcare workers, as you can tell, is relatively unchanged from last week or the week before. So the situation remains very challenging, very difficult, but it is not getting demonstrably better in terms of overall sickness or worse over the last couple of weeks. It is staying remarkably, in fact, similar in terms of the statistics. I want to thank everybody working in healthcare. It goes without saying, I think, but we should say it again and again if we can, who've been working exceptionally hard under enormous pressure to get British Columbians through this pandemic and to provide exceptional services in communities across BC. With respect to rapid tests, BC has received, as of January 31st, 2020, 10,187,385 rapid tests and deployed 5,927,284 of these tests to key strategic area. This leaves a current inventory of 4,260,101 tests, 2,658,000 of which we received in the last 3 days, so since on the weekend and since. As you know, as we've discussed before, 556,896 of these tests are not packaged suitably for takeaway or personal use, leaving 3,703,205 tests that are suitable for self-administered use. This week, subject to timely delivery from the federal government, we will be working to deliver over 1,291,000 test kits as follows: 351,000 for repackaging and distribution to COVID test sites across BC to replenish their supply, 100,000 to replenish supply at acute care centres for symptomatic healthcare workers and health authority programs, for example, emergency departments, 260,000 to support testing of visitors and symptomatic staff in long-term care and symptomatic staff in assisted living, 130,000 to support rural, remote, and Indigenous communities, 300,000 more tests to support K-12 education, As more tests arrive, we will continue to push to the areas in greatest need and expand across post-secondary childcare and other areas, as identified in the plan that was presented on December 21st, 2021. Currently, BC, and this is a change, expects to receive 16,597,515 tests between today, February 1st, and the middle of February. This is an increase from the 15,719,920 that we were expecting as of January 20th, and an increase from the number that we provided last week. This is good news. Clearly, the supply of tests is substantial, but it's also in flux as orders and deliveries get firmed up by the federal government. And finally, I want to provide our weekly surgical renewal update. Health authorities reported in the week of January 2nd to January 8th, which included a statutory holiday, 4,976 surgeries were completed in that week. From January 23rd to January 29th, health authorities postponed 870 non-urgent scheduled surgeries. That's 104 in Fraser Health, 15 in Vancouver Coastal Health, 572 in Interior Health, 171 in Island Health, 8 in the Provincial Health Services Authority. No surgeries were postponed in the Northern Health Authority. And just to put that in context, that's a significant number, and it's impacting a lot of people and a lot of families, although it's significantly less when the suspension of non-urgent scheduled surgeries in the April and May 2020 period in the first phase, the first wave of the pandemic. Cumulatively, from September 5th to 2021 to January 29, 2022, regional surges of COVID-19 and factors including severe weather patterns have caused 6,762 surgical postponements. As reported, there are over 1,000 people, and there will be today, in hospital with COVID. There's still a very significant number, although less relatively speaking compared to the total number than before in our intensive care units. And we're still losing loved ones to COVID on a daily basis. While there's more important progress on other fronts that reflect our hard work to stop the spread, we know this, and this is something we do together in British Columbia, and we've done together very effectively. We know our work is not done. We know this too, that our actions to slow COVID's current surge have a direct impact on our healthcare system's capacity to perform in the many ways we count on it to perform, to do the many things we rely on it to do, and to deliver the remarkable outcomes we've come to expect from it. Patients will get their calls to rebook their surgeries. Healthcare workers and teams will get the respite they need from COVID's current push. And all of us will share in the relief those achievements bring when we continue to do the work that so many are counting on us to continue to do. Keep wearing our mask, keep using our physical distance, keep using our COVID sense, keep adhering to health orders, keep embracing health guidelines, keep getting vaccinated in these exceptional numbers, and keep protecting our children with their vaccinations and getting our third shots and boosters when it's our turn. That's our work, and when we do it, we make all the difference in the moments that matter. And with that, we're happy to take your questions.
As a reminder to reporters on the phone, please press *1 to enter the queue. You will be limited to one question and one follow-up.
And I'm just going to give a quick update on one other issue that I missed my notes on. We talked last week, and the National Advisory Committee on Immunization came out with recommendations around booster doses for 12 to 17-year-olds. And they did confirm a 6-month interval was the interval to be used. They also confirmed, and this is something that we'll be making sure people have access to later this week, that people who, similar to adults who have, in the 12 to 17-year age group, who have clinically extremely vulnerable, have immune-compromising conditions and a few other conditions, should get a third dose as part of your primary series, and then a fourth booster dose 6 months after that. So that will affect some people who are immune-compromised in that age group, and you'll be receiving your invitations for that. For other people in the 12 to 17-year age group, NACI has recommended that a booster dose be provided to people who are at high risk, and we for a number of conditions, and we have those outlined at 6 months of age. So that's people with diabetes, people with a number of other conditions that increase the risk of having more severe illness. And for others, it is, in NACI's opinion, more of an optional risk-benefit analysis that you do yourself. So how we will be doing it here in BC after discussion with our BC Immunization Committee and our immunization team, we will be sending invites to all 12 to 17-year-olds with information on the benefits and risks of boosters at your 6-month interval. And you will have the ability to make that decision and book yourself. And we do, of course, continue to strongly recommend that anybody who has an underlying condition that puts them at risk does get their booster dose. We have seen, and we see it in the hospitalization data, that it's important for protection not only against infection, even from Omicron, but also really important for longer-term protection against severe illness. So I'll leave that at that, and then we can start for questions.
That our first question today will be from Binder Sajan, CTV. Please go ahead.
Dr. Henry, I know you said that the information would be up on the website, but can you explain a little bit about how the criteria for declaring an outbreak in care homes is changing, what it's going to be? And we're hearing that this change may have been made in late December or early January. Can you tell us sort of when it goes into effect or when it went into effect and exactly what the new criteria are, please?
So, as you know, we had guidance that was posted up on our on the BC CDC website, and these are public health guidance that MHOs use on a case-by-case basis to make a determination. And they're based on the information, and I've talked about this a few times, that we have from our regular respiratory infection outbreak guidelines in long-term care homes. And so they were quite prescriptive about the things that must be done if there was evidence of transmission within a facility. So that included a single positive case in a resident or more than one case in a staff person where there was transmission within the facility or potential exposures. So that was an important, very sensitive definition that served us well with the serious illness that we were seeing with multiple different strains of the virus, and particularly before we had vaccinations and before we had booster doses. So we are now seeing it is qualitatively very different in long-term care homes with the Omicron. And because there's so much spreading in the community, we see rates, background rates in long-term care homes as well. So it is much more around a changing situation, whether there's severe illness, so more symptomatic illness. We're no longer doing asymptomatic testing, screening of everybody, looking at who's getting the vaccination levels, whether it's more serious, whether other respiratory viruses are calling it. So it has always been at the judgment of the MHO doing the investigation of each of the outbreaks, but declaring an outbreak is a little more nuanced now based on what we're seeing in a highly vaccinated population, both workers, visitors, and residents in particular. And the measures that we're putting in place in an outbreak are not as extreme as the ones that we had in place. And I talked about, overall measures, but especially outbreak measures. So still ensuring that a vaccinated, protected visitor can come in for every resident, even during an outbreak, so that they get that extra support that they need, for example. And there's a few other things that are part of that as well. And yes, this has been an evolution, as we've, very similar to the hospital data, as we've seen Delta fade away and Omicron causing very mild illness in many cases in both staff and residents.
Binder, did you have a follow-up?
Yeah, I just wanted to ask about the rapid test. It seems like pretty big numbers are coming in now to the province. We know people now are turning to Facebook groups, for instance, to try and find out which pharmacies may have them, and wondering why they don't have access to some of those rapid tests that are now coming in this month. Some people need to know or need to show a positive test for work purposes, for taking sick days, but is there a plan to distribute those rapid tests that are coming in a more, where people can just pick them up at testing sites, because, people want to know whether they have COVID or not?
Yeah, I'll let the minister take that one.
Sure. So we laid out a very detailed plan, been there on December 21st, as to where our priorities were for the use of rapid tests. British Columbia, as you can see by the large numbers coming in to the province, are getting its full share of rapid tests, 13.5% of the national supply, and we're using them in these priority areas. So I think I noted that if you're talking about 10 million rapid tests, that's less than 2 per person, and we're using them in priority in areas such as long-term care, acute care, to support our testing sites where they're there, in schools, in post-secondary, and some work sites, in areas where there's congregate living and others, to ensure that people are safe. And that is, you see in detail today, the way those tests are distributed across the system. So that's what we're doing. As we get more, we may be able to extend that more widely, but those are going to continue to be the priorities. Priorities are going to continue to be our healthcare system, continue to be supporting K-12 education and post-secondary education, continue to be to support childcare, continue to be to support certain workplaces where the risk is highest. And they're, of course, a part of today's announcement around visitors in long-term care. So that utilization, as you can tell by the numbers being distributed to those areas this week, I think it's about 1.3 million. That's a lot of use of rapid tests across those systems of the supply we get. The rapid tests we're going to use. And the only exceptions to that are the ones that we're drawing down more slowly, which are ones that require specialized equipment or a healthcare worker. And so we're going to continue to do that over time. And obviously, as we get more, we'll be able to somewhat widen that. But those are going to continue to be the priority areas. We laid it out in detail what we're doing. And it's not dissimilar to what lots of other jurisdictions are doing as well. But this is our priority, which is to protect the most vulnerable, protect the healthcare system, and to ensure that critical things, such as to support critical services for parents and children, such as K-12 education, childcare, and post-secondary education.
Our next question is from Rob Shaw, Czech. Please go ahead.
Could I just get you to walk us through the essential and designated visitor situation again? I guess I find it a little bit confusing. If seniors have essential visitors now, but only 1/3 of them actually have that declared, and the concern is that it's the care home administrators who can decide if a senior's essential visitor is actually an essential visitor. And you said today, during an outbreak under the changes, essential visitors can still go in and visit. Can a designated visitor still go in and visit? And a designated visitor doesn't have to be approved by the care home administrator. Could you just walk through the differences there and what it means for seniors?
That's absolutely what it means. So we have a process in place already, and as we've mentioned, about 1/3 of seniors and residents of long-term care have somebody who needs to be there as part of their care team, helps provide that extra care, and those people have been identified already. What we are moving towards, and what we have moved towards, as I've mentioned since the end of December, is making sure that in addition, every single resident at their choice can designate somebody to be their visitor, and you can have a backup in case somebody's ill or can't come in. So yes, if you have 2 children, one of them can be your essential visitor if they're already designated, and you can have another person come in to be your visitor. And that's what we want across the board. That's what's aligned with what the representative for seniors, or the seniors advocate, has suggested, whether we think is really important. And they, yes, can come regardless of the transmission rates in the community, regardless of whether there's an outbreak in a facility. They will need to be, because we know that it's still pretty risky, they'll need to be vaccinated themselves, and that's why we're prioritizing long-term care for making sure we can test people with rapid tests as well. So those are at the resident's choice, and every resident is entitled to have their designated visitor who can come at any time, and that's in addition to those people who have already been identified as essential visitors. Does that make it clear?
Rob, did you have a follow-up?
Great, thank you. Yeah, Minister Dix, could I ask you to comment on the Victoria woman who yesterday got a call from nurses at Royal Jubilee Hospital to come and ask her to come feed her 87-year-old mother there her 3 meals because there wasn't enough staff. Apparently, the family had to do that again today as well. Is that acceptable? Do we know if other families are being asked to do this? And what happens if a patient doesn't have family who can come in and feed them?
Well, to the latter question, no one's ever denied, obviously, care or left without being fed. And so that simply doesn't happen and would not happen in those circumstances. What does happen, and I can't comment on the case, just so that everyone understands that regardless of the public comment around the case, we can't comment with the information we have, which are part of the privacy afforded to people in our healthcare system. So we don't comment on the individual cases. What happens, and what happens frequently, and this is before the pandemic and now, is that visitors frequently help with care, either because they want to or because it's the patient who's a relative may ask them to, or because the care staff think that's a good idea, and that frequently happens before and after. So it's not an issue of the individuals being called in to do that, but that it can be a helpful situation for many involved. There's no question that there's staffing challenges. You saw in the numbers we provided in Vancouver Island Health right now, but there's also no question that everyone is going to be fed in that process. But sometimes people get asked to come in and help, especially when they're providing care around. And again, this is not about this case. I'm not commenting about the case, but and that I think happened before the pandemic. It happens now, and will continue to happen. So the issue isn't that people aren't going to be fed. Of course they're going to be fed. The question is whether staff ask for a variety of reasons for family members to come in and assist, and often that's a very good thing. Sometimes for the family members, sometimes certainly for the patient that happened. But in no circumstances would someone not be fed, and I think that would probably be obvious to everybody. But this is an important question, and I'm very appreciative of the family's concern. And if there's specific complaint, there's an independent process to review those complaints. I encourage people to take it to those processes as they have complaints about the healthcare system, because that's important. It's also important to know our care staff, and it's been one of the challenges throughout the COVID-19 pandemic in long-term care, as we've just discussed in acute care, is often families and visitors play a very important role in supporting the care and the recovery of people in both acute care and in long-term care and in other health circumstances. So the short answer is everybody gets fed, but this is not unusual that visitors, whether they be essential or otherwise, be asked to contribute to that. And I gather, without commenting on it, but from hearing what's been reported in the news, that's what happened in this case. But those are the circumstances anyway, and obviously we want to make sure that everybody is well treated so that their recovery and the support for whatever brings them to hospital is well supported in our system.
Our next question is for Richard Zussman, Global News.
Dr. Henry, Pfizer is now working through the process of getting its vaccine approved for those under the age of 5, so I think from 6 months to 5 years old. At what point do you expect to see that vaccine available here in British Columbia? And what would your initial thoughts be around people of that age getting the COVID-19 vaccine?
Yeah, so yes, I've been watching that with interest. This was the FDA in the U.S. Suggesting that Pfizer start the process of applying for emergency use authorization, which is slightly different from the process that we have here with Health Canada. And we've talked about this before, that the initial dosing tests on children in that age group indicated a 1/10 dose, so slightly different from the pediatric formulation we have right now. But the immunogenicity studies they did, so that's seeing if they give that dose to that age group of children, if they have a similar antibody response to what we see in adults that we know is protective. So it's what we call a correlative immunity. And what they found was they weren't getting as strong an immune response. And partly this is because our immune system develops over time when we're very young, and sort of the ultimate time frame for a strong immune system is in that sort of 6 to 15 to 20 year age group, which is why we see such great benefits from vaccine in the kids in that age group and in teenagers. So the short answer is they are continuing, and the FDA and others in the U.S. Asked Pfizer to add a third dose to the protocol for that age group. But what they're doing, given the rates of transmission they're seeing and the hospitalization rates in younger children in the U.S., the FDA has said, go ahead and put in the application with the data that you have for the first 2 doses. And then by the time we have the opportunity, as we have seen, it takes months in many cases to review that data, to understand the data, and to look at it in detail. They should have results of the third dose part of the study. So it is looking at ways of starting immunization programs for younger children in a high-risk environment where there's a lot of transmission still in many parts of the country, as the continued testing of how many doses is actually needed is ongoing. So that's kind of complex. As far as I know, Health Canada has not yet taken that approach, and we're still waiting for the information from Pfizer and the data on the first 2 doses and the third dose. Having said that, it is important, and we have seen young children being affected by COVID. We've had admissions to hospital in the 0 to 4 age group. We've had 2 young toddlers, 1 toddler, 1 infant, who've died from COVID over the course of our pandemic. And we know that it can cause severe illness in young ones. So it is important that we have a vaccine that can protect especially those highest risk children in that age group. And we'll be looking to Health Canada to review the safety and effectiveness data as it becomes available here. I don't think it will happen in the short term, but I do expect that as soon as Pfizer gets the more detailed data, they will submit it here and to Health Canada as well.
Richard, did you have a follow-up?
Dr. Henry, I'm receiving a lot of notes from people who are trying to plan trips outside of the country for spring break. And one of the challenges they are facing is around a potential COVID diagnosis. Because of the limited testing capacity here, many of them are not able to get tested. As you are aware, I'm sure, if you have a PCR test confirmed, there are certain rules around travel in terms of getting retested. All of this considered, would BC consider providing documentation for those who tested positive on rapid tests to allow for that travel? And what conversations have you had with your federal counterparts around changing some of these confusing travel protocols that could be prohibitive for people who in BC were never able to get a PCR test?
So this is not unique to people in BC, and yes, there are some. I will say that the publicly funded testing system is not for private personal travel like that. So no, it's not available in our PCR tests in our publicly funded system needs to be focused on the people for whom it'll make a difference in terms of either their care or going back to work. There are some provisions in places, I know in private clinics, to be able to get a confirmation associated with a rapid test positive at a person's own expense, like other travel clinic services that are provided. It's very hard to, as you know, there's a trajectory of antibodies that are picked up by these tests. So if we're talking out in March, somebody who had an infection now is unlikely to test positive on a PCR test that far out. But those are things that are very challenging things. And yes, the federal government is reviewing, particularly as in the provinces and territories, we've changed our isolation requirements for people who are contacts and for people who test positive, and they're not aligned anymore with some of the border measures. So we have had ongoing discussions about the border measures and what tests are required when and why, and I know they are reviewing those in the next few weeks.
Our next question today is from Lisa Cordasco, Vancouver Sun. Please go ahead.
Thank you. I want to talk about the changes to how you are going to adjust outbreak management, your management approach. In changing when a medical health officer may declare an outbreak, some would say that, outbreaks should still be declared because then visitors and residents of care homes know and can judge whether they will continue to go to activities or whether visitors will be continuing to visit. Declaring an outbreak just simply tells the public that there is COVID circulating in a care home. Medical health officers from that point on could use their discretion to say, yes, visits will continue or activities will continue. Is that the approach that you're using? And if not, if leaving it up to declare an outbreak in a care home, how are members of the public or, visitors or even residents in care homes to actually know that there is a COVID circulating in their facility?
There's lots of things that are packed into that, and it is a little bit. The MHO is not in every facility every day, and of the 200 and some that are in our province, and it is that community that understands what's going on. And yes, we liaise with each individual facility. The facilities themselves and our teams in the regional health authorities, that include the MHOs, it includes infection control. They are in constant contact with the different facilities about what they're seeing. So the people, what we're seeing now is that, yes, there may be a resident who tests positive for COVID, might have mild symptoms but test positive, and they are individually isolated in their room. We have overall provisions in place so that you only go visit your one person, you wear a mask, you're tested, staff are tested regularly. If they have any symptoms, they wear PPE all the time. So there is measures in place that help reduce the risk of transmission. And there are people who are asymptomatic who have this in our community now, and that includes in long-term care homes. So all of these other things help reduce that risk. And if somebody tests positive, they know, their roommates know and are isolated. If they have roommates, their families are notified, and they aren't able to participate in group activities. So it is a matter of finding that balance of knowing if there's a few cases, but there's not a lot of transmission happening. You can isolate those individuals very effectively now because so many people are vaccinated and because we have these other measures in place. So that's on a home-by-home basis how we're managing right now. And then if there's more transmission that's not, that we're not sure who's passing it to who, it's more severe illness, and we've had that with RSV and we've had it with Delta still causing a couple of infections, then we need to take more additional measures and give more detailed notification to the broader community. But it is trying to find that disruption of people's life and ability to be with their loved ones versus risk right now.
Lisa, did you have a follow-up?
Yes, I can appreciate that care homes would be taking measures to reduce risk, but my question is about the declaration of outbreaks. That triggers an actual public warning that COVID is circulating in a care home. People can make their own decisions after that, and including medical health officers to decide, what protocols are going to take place in any care home. My question is, you're abandoning that requirement that people be informed if you don't declare an outbreak. So, and then not declaring an outbreak and giving them all kinds of options. Aren't we going to be all over the place with where an outbreak is and isn't and what's going on and isn't going on? Why not just declare outbreaks and then decide protocols for handling it? Leave that to the discretion of medical health officers.
This is what we do in long-term care homes, have done for many, many years. And it is about finding that balance and that judgment. And if there's not COVID circulating, we may have cases, we may have individual people, we may have rooms where there are individuals who have COVID. There may be a number of staff who have COVID who are off and no longer in the facility. Those don't constitute circulation within the facility that puts people at risk right now. So it is finding that balance and that judgment, and we don't need to tell in a 300-bed facility that one person has COVID. It's finding that balance right now, given what we're seeing circulating. And it is very much a part of a relationship that we have, and a really good relationship now, where people are taking additional measures on a daily basis to make sure that they're protecting themselves and their loved ones and their fellow workers in long-term care homes.
Our next question is for Lisa Yusta, City News. Please go ahead.
Hi there. I'm wondering, with all the information that you've laid out today, Dr. Henry, and talking about, you sound a little bit optimistic that by February 16th, at least some things are going to be lifting. But laying out, how it's affecting hospitalizations and ICU, are we sort of looking at going the way of Denmark and England, that we are really going to see a large lifting of regulations in the weeks or months to come?
I think I made it quite clear that we're still on the ratcheting up the dial versus on and off switches. So there's some things that we know are working and give people the ability to do higher risk activities more safely. Things like the BC vaccine card, these things like some of the higher risk settings having capacity limits. So wearing masks in indoor settings, especially some of the higher risk indoor settings. So there are some things that we will need to continue to do for another period of time. I do absolutely think that we'll be able to lift them at some point and we'll have no restrictions. But I do think at some point we're going to get to a place where we can think about having those important life events again in a limited way, and gradually increasing that to a place where we can have larger groups of people together for wedding ceremonies and celebrations of life and birthday parties and all those important things that we've been missing this last few months.
Lisa, did you have a follow-up?
I do, and this one's probably more for Minister Dix, but not sure. Regarding the rapid tests and your response, I think Richard asked the question. So you're saying that there's 4.2 million that are around right now, 500,000 can't be used. And so that's, nearly 3 million sitting there. So I guess people are left scratching their heads why there isn't a process by which more people can have access to them when there's that many that seem to be sitting there, when they're just, people really haven't seen them much at schools. I think they're starting to trickle in, or at universities. So is it just that we haven't seen them in broad numbers at those places where people want to access them, and people are really scratching their heads about why they can't be more broadly accessible when there's this many millions sitting there?
But I think I'll add to that. There's 600,000 children in K to 12. There's another, how many staff are in K to 12, plus post-secondary institutions. And so, 3 million sounds like a lot, but they're also packaged in packages that they're not 3 million individual packages of tests. And that's, 3 tests for every school child. So it's not a lot when you look at it from that perspective. So, and yes, they are getting into those settings now, and many of them just came in the last couple of days, as you know. But I'll let the Minister talk to details.
So you talk about 3 million tests. We've had tests in the millions come in the last 3 days. And what happens is we come in, we process them, and then they go out. And I laid out in detail where 1.2 million are going this week. So what you're seeing, I think, is us taking the tests when they arrive. They're not always consistent on their arrival. And then distributing them to the areas of priority. And those areas of priority, again, are acute care, testing centers, long-term care, assisted living, schools, K-12, schools, post-secondary, child care, workplaces, congregate settings, and others that are priorities and have been designed as priorities by public health and by those who are driving the initiative. So there's none sitting around. We get millions come in. It takes us some days to process them, and then they're going out. And that's what you're going to see. You're going to see a significant increase in that number in the next couple of weeks. So the next time I report, there will be many millions more arrived and many millions more distributed. And so nothing's waiting around, and we're giving priority to those areas where we can have the biggest impact on the pandemic. And those are the areas I've described. And that's what we're doing. We're getting the tests coming in the millions in a given 3-day period, and then they're also going out in the millions, and that will continue to happen. So if you take it at a point of time, when 4 million tests, say, arrive one day, and you say, well, there are 4 million tests, well, those will be going out to those priority areas, and you'll be seeing them around the province. And obviously, we've been doing dramatically more rapid testing in the last few weeks as a result of the tests we have.
We have time for one more question. Our final question today is from Belle Puri, CBC. Please go ahead.
Dr. Henry, by the end of this month, children 5 and up will have had time to get both doses of the vaccine. So, and many of those in that age group have already been exposed to it or have been mildly sick and recovered from Omicron. So given all of that, when do you think school might return to normal? You know, masking would be optional, no social distancing, field trips would be allowed, and we need an answer in French as well, please.
Yeah, you know, one doesn't, I'm continually reminded of the travails of speculating. You know, I kind of thought we were in a really good place in December until Omicron hit us. And we still are seeing this virus spreading rapidly around the globe. We still see new things coming up every day, whether it's, you know, the BA.2 in Denmark and the UK and South Africa now too. And we've had some of that here. So there's a whole lot of things that we don't yet know. And some of the more challenging things to implement in schools are the ones that we hope to get rid of first. But it will depend on decreasing circulation rates in our community and our balancing in our healthcare system. So I do think, you know, by the time we get to spring, we're going to be in a very different place, I hope, at least for a period of time. And this is my speculating a little bit, with recognizing my optimism bias. But I do think with the level of immunity that we have, with the level of protection we have through vaccination, with the amount of milder illness in those vaccinated people, that gives a boost to your immunity for a period of time as well, that we're likely to have a gentler spring and hopefully summer. And we'll need to prepare ourselves in all areas for more unknowns come the fall, because it is pretty sure that this virus is going to come back in some form in the fall, and hopefully it'll be in a form that is still, we still have good protection from the booster doses of vaccine that we've had, and that we can manage our healthcare system.
Oui, ce que la Dr. Henry vient de dire, c'est qu'il est possible que notre printemps va mieux qu'aujourd'hui, n'est-ce pas, dans le contexte, et ça va être plus dur qu'actuellement. Mais cela étant, on vit un moment où on a plus d'un millier, à l'hôpital, 30 à peu près, ou à 40 en ce jour-ci, et un taux de positivité de 19 à 20%, ce qui est important quand même dans le contexte de l'histoire récente de COVID-19, c'est-à-dire que c'était de taille de 3% au commencement du mois de décembre. Donc, nous vivons une période mouvementée difficile. Et je pense que nos enseignants, nos professeurs, nos administrateurs, nos étudiants, nos parents font un travail extraordinaire dans des circonstances. Bien entendu, on veut que ça va mieux au printemps, et ça se peut, surtout pendant l'été, ça se peut, et c'est plus que se peut, c'est à ça qu'on s'attend. l'automne et l'hiver prochain va encore présenter des nouvelles difficultés à tout le monde. Donc, je pense qu'il faut maintenant rester stable et calme, et c'est difficile. Et le travail effectué par tout le monde dans le système scolaire est extraordinaire, mais difficile. Et on espère que ça va mieux, mais ça ne va pas être la semaine prochaine ou même le mois prochain.
Bill, did you have a follow-up?
Dr. Henry, I think you said 60% of COVID cases in hospitals or among patients admitted for other reasons. So how much is that related to the policy of not keeping COVID patients separate, putting them in rooms with vaccinated people? How much is that a contributing factor? English and French, please.
I'm not sure I understand your question. Are you asking whether there's been transmission in hospital because we've put people with a COVID positive test in a room with somebody who's low risk and COVID negative?
Right. Like, I mean,
I'm not
we're
aware
hearing
of any transmission.
COVID patients in.
So, what we are seeing is people are being admitted to hospital for surgery. Actually, where we're seeing it most commonly is surgery. People being screened for surgery, people being screened at labor and delivery, people being screened for mental health and substance use admissions, and some of them are testing positive. They are asymptomatic, and precautions are put in place to make sure that while the period of time that they have a positive test, that they aren't able to transmit it to others. But I'm not aware of any transmission from having people in a room together, I guess, unless I'm missing the question. Sorry.
Bill, did you want to clarify your question?
Well, no, I think we've been hearing that COVID positive patients and vaccinated people are in rooms together. So we're just wondering if you've had cases of transmission in those situations. Do any of these people who go to hospital for a non-COVID reason then end up being positive for COVID? Did they get it there?
Yeah, so we have had a number of acute care outbreaks, as you see in our outbreak report, and that's where somebody was unknown to be to have COVID, and it's been transmitted in a acute care setting. But there's been no transmission from a known COVID positive person being placed in a room or ward with other vaccinated, low-risk people, according to the infection control policy that we talked about a couple of weeks ago.
Juste pour dire qu'il y a des éclosions dans nos hôpitaux de temps en temps, mais les statistiques d'aujourd'hui, les chiffres démontrent maintenant petite majorité des gens qui viennent à l'hôpital, qui sont après cela déclarés positifs au COVID-19, après un test, viennent pour d'autres raisons. Et ça, c'est un changement depuis la période Delta, où une petite minorité des gens dans la société, c'est-à-dire quand c'est 3% de la société, il y a beaucoup moins de gens qui arrivent à l'hôpital pour d'autres raisons, qui quand même sont positifs pour le COVID-19, n'est-ce pas? Donc ça, c'est un changement. And I think what we see, and this is a difference from the Delta period, when you have overall test positivity of 3 or 4% in the society based on our PCR testing as a sample of the overall society of people, and that goes up to what it's been, 24%. And you're going to see an increase in the number of people who aren't coming in for COVID, but are coming from other reasons, but are also positive for COVID. And that's what we're seeing, and that's what the numbers reflect. The change, the approach to how we treat people in the hospital continues to be the same, where possible, when people are positive for COVID-19, it is they are cohorted away from the general population. It's just not always possible when you've got, as we did today, 9,300 people in hospital and 1,030 or so of them are with COVID-19, and that's in different hospitals. Those numbers, of course, individual hospitals are different, so cohorting is not always possible, but it's certainly the direction, and Fraser Health was making some adjustments to that. But what you're seeing is not evidence of what you're talking about. What you're seeing is the change in the pandemic from Delta to Omicron. And with that, merci beaucoup. Thank you until the next time. Thank you.